All right, good morning, everybody, or afternoon, evening, whenever you may be watching this. Today, we're going to be talking about our primary assessment as it relates to our skills sheets, our medical assessment sheet in particular, which you guys have just gotten the other week. Uh, so, uh, in taking into consideration everything that we've learned in Chapter 12 about the primary assessment, we're going to put it into practice with our skills sheet. And as you know, as we've talked about, it's going to require you to form a dialogue, basically a script that you can go off of as you're doing the primary assessment with these things. Um, and it's important to figure this out because this is going to get you into the rhythm of the call, how to talk to the patient, how to move through the call systematically in doing your assessment, and how to gather and organize information that you're getting from the patient to figure out what's wrong and how we can take care of them. So let's take a look. I'm going to share my screen here. All right, here's our medical assessment page that we're all familiar with here. So as we know, these simulate real life calls from when we're arriving on scene. That would be our scene size up, all the way through transporting the patient to the hospital. Just like in real life, when you're doing one of these, you're going to get dispatch information. Why are you going on the call? What's the reason for going on the call? Sometimes this can be a little bit vague and not very specific. And sometimes it can be very specific. For example, gone on many calls where we're being sent out for the unknown medical emergency. They're basically telling you something's going on, just go there and figure it out. Obviously, that's really vague. And other times it can be very specific. You have a 65-year-old male having chest pain. He has cardiac history and everything else. So sometimes you might get a lot of information there. So when we're doing these, as we know, we're going to have this dispatch information. So for this, as we're going through it, let's just say it's something very simple, something that we can all imagine right now. All right, we're going to say, as we're going through this, that our patient is having chest pain. Sometimes in the dispatch information for these assessment sheets, we'll get some additional information beyond the chief complaint. So let's say that our dispatch information is the following. You're dispatched for a 70-year-old male who is having chest pain. When you arrive on scene, you note that the patient is looking worried. Their skin is diaphoretic, and the patient is displaying the Levin sign. They're clutching their chest. They're holding their chest where they feel chest pain. So that information gives you a little bit of what you're seeing when you do your general impression there for the patient as well. So that gives you just a tad bit more information, which can actually give you a lot of information about what's going on and how the patient is feeling. All right, so let's use that as an example as we go through this sheet. We know our scene size up. We should be practicing that, and we should be getting basically fluent in our scene size up at this point. If you can't do your scene size up at this point without the sheet, you need to get in there. Okay, we need to be able to do this. It's very quick. As we know, it only takes about 5 seconds or so to get through it. And it takes practice. You have to practice these things because eventually we're going to be doing this entire sheet without the sheet. It has to be memory based. You don't have these sheets in the ambulance with you. We have to move through this without these. So if you can't get through your scene size up yet without the sheet, get practicing. And if you can, excellent. Now we're just going to add in the primary assessment to it. All right, so let's get started here. So again, our dispatch information, 70-year-old male with chest pain. When you arrive on scene, you can tell that the patient is looking worried. Their skin is diaphoretic, very sweaty, and they're clutching their chest, holding their chest for the chest pain. So let me go through this for you. So we're going to start with BSI, right? Jazz hands. BSI. Is my scene safe? My scene safe. The nature of illness is chest pain. I have one patient. I'm going to go ahead and request ALS, and I don't need to take C-spine at the moment because there's no signs of trauma. My general impression of the patient, as we move into our primary assessment now, my general impression of the patient is poor because of the patient's appearance. They're sweaty, diaphoretic, and they're clutching their chest. They're showing positioning there. So my general impression is poor. I'm going to ask the patient at this point, this is where I introduce myself to determine responsiveness and level of consciousness. The easiest way to do that is to talk to the patient. So I'm going to introduce myself at this point and say, how you doing? My name's Joe. I'm with the rescue squad. Can you tell me what's going on today? Hopefully your patient is going to respond and they're going to say something like, oh, I'm having just terrible chest pain. It started like an hour ago. I was moving boxes around in the attic and it just started hurting really badly. And it just feels worse and it's not stopping. So after your patient tells you all of that, you're going to be able to say, well, their level of responsiveness, they're alert and oriented because they were able to talk to me and tell me what their chief complaint is there. Their chief complaint is chest pain there. So it's really easy, those first three boxes, right? You give them your general impression, and you introduce yourself, you get them to talk to you, tell them what's going on today. If they're talking to you, if they're responding to you appropriately when they tell you about what's going on, then you can say that they are responsive, they are alert and oriented. The only time really, if you have to ask the questions about person, place, time, is if you have any suspicion that they are not operating at full capacity, mentally speaking. That is, is there confusion? Can you see it in their eyes, in the way they respond? Things like that. Are there any clues that they might be hypoxic that's causing an altered mental status? So it's really easy to determine that level of consciousness there when they are conscious. All you got to do is talk to them. And so if they respond normally, they're going to be alert and oriented. The chief complaint, obviously that's easy to determine because they're going to tell you. They're going to tell you. So, and in this case, our patient tells us that they're experiencing chest pain. All right, so now that we've gotten the general impression done, level of consciousness, and chief complaint, we're going to move into our ABCs. Now, with this patient, a chest pain patient who is conscious and talking, they have signs of life, we're going to follow the ABC route. We can start with airway, then move to breathing, and then assess circulation. So airway in these kind of cases is really simple. If they're alert and they're talking to you, their airway is open, okay? But remember, we have two questions to ask every patient. We have to ask ourselves about every patient about their airway. Is it open and is it going to stay open? So in this case, because the patient is talking to me, it's open. And we don't see any signs, anything like allergic reactions, traumas, burns, anything like that, that would indicate that the airway wouldn't stay open there. Maybe a possibility would be if the patient, is suffering a large heart attack and they go unconscious or unresponsive. At that point, we'd have to reassess the airway because maybe it wouldn't stay open then. But right now, because they're conscious and they're talking to us, it's patent and self-maintained, right? So those are the words that I'm going to say right there. I'm going to say, as I'm moving into airway, I'm going to say, the patient is talking to me, so I know that their airway is patent and self-maintained. That means it's open and it's going to stay open. All right. So that's our airway section. Right? Because he talked to us, it's open and it's going to stay open. In the same box here, it says assess airway and breathing. So we'll look at breathing next. We have to assess our patient's work of breathing. That's the first thing that we're going to look at, right? Is their work of breathing. Are they working hard to breathe? We know, we've talked about it, that breathing normally, it looks easy and it's quiet. So if we see or observe anything with our senses, we see or we hear it, that somebody is struggling to breathe, there's an issue, right? And again, we have to ask two questions for breathing. Are they breathing, and is it adequate? So if we're not seeing somebody work really hard to breathe, if it's not noisy, things like that, then it's most likely going to be adequate. So we're going to look at this person's work of breathing. When they talked to me, a good indicator of their breathing is that this person, when they said they were having chest pain and they got it because they were moving boxes in their attic, things like that, he was talking to me in full sentences. They weren't choppy. They weren't like this, where you can only get 2 or 3 words out at a time. Right? It's not struggling like that. It was just a full sentences talking normally. So that is a really good indicator that the work of breathing is good. The breathing is adequate. They're not struggling to breathe. They don't feel short of breath. The breathing at this point, it looks good. The work of breathing looks good. But what I'm going to do also here, not only am I going to observe them with my senses, I'm going to look at how they're breathing. I'm going to listen to how they're breathing just quickly. And when I say listen, I don't mean I'm putting on the stethoscope right now. I'm just listening with my ears here. Once we get through that quick assessment of them, what I'm going to do is I'm going to put the pulse oximeter on as well, because at this point, we're also going to do any oxygen therapy that we may need. Here's the important part about the oxygen therapy. Whatever we do, our goal with the pulse oximeter is to get the patient's oxygen saturation levels to 94% or above. Right? That may not make sense right off the bat, because you're thinking, well, you told us, Mr. Whalen, that 94% was mildly hypoxic. And you're right, I did. And that's okay in these situations. It's just below normalcy. Okay, so we're looking for 94% or above. That's the goal of our oxygen therapy, is to get them to 94% or above. So, and we're going to learn later about, when we talk about heart attacks and strokes, about the dangers of oxygen therapy for them. We don't want them to be all the way up at 100%. So when we give oxygen therapy, we're going to titrate it to effect. That means I can give them some oxygen, get them up into the range that I want to be, and then kind of play with the oxygen levels to keep them around 94, 97%, wherever it might be in there, just 94 or above. We don't want to put them to 100% in this specific case, but maybe I put if their oxygen saturation levels are below 90, I put a non-rebreather on them until they get up to about 94. You blast them with oxygen, fill their red blood cells up with oxygen. And then once they get to that 94%, maybe I turn that oxygen down a little bit. Maybe I just switch them over to a nasal cannula at that point, but just to get them to 94% or above. All right, so our breathing, again, we're going to look at work of breathing. We're going to assess them with our senses. We're going to look at them to see how they're breathing. We're going to listen to them, to listen to how they're breathing. Is there any indication that the breathing is inadequate? And in this case, it's not. We'll go ahead and say that our patient's oxygen saturation levels are at, let's say, something very normal, like 97%. If that's the case, I don't need oxygen. Right? If they're 94% or above, we're not going to need the oxygen. If they're below that, we'll get them on oxygen to get them to 94% or above. All right. So in this case, I don't need to give oxygen because he's at 97%. All right, and that'll take care of our breathing. Then we move to circulation. All right, there's three things that we need to assess in circulation. The first is going to be life threats. All right. So we've been looking for, as we're going through ABCs, we are looking for life threats. Is there a threat to the airway? Is it going to close? And we're going to look for threats to breathing. Is it adequate or inadequate? And what's the problem there? And for circulation, the life threat is going to be bleeding. It's going to be bleeding. That's going to be the big one. Okay. So the first thing we're looking for is major bleeds that could kill this person here in the next couple of minutes. So we're looking for any major bleeding. Signs of major bleeding could be, obviously their clothes are covered in blood. They're sitting in a big blood puddle, things like that, right? They're really pale and diaphoretic and breathing hard. That could be a sign of they're bleeding internally or externally. It doesn't matter. It's a sign of shock there. So in this case, it's a medical patient. We don't have any bleeding. So we're going to say, I don't see any bleeding that needs to be controlled. And then we're going to check the pulse as well. We're just going to feel the pulse. We're going to feel it for about 10 seconds. And there's three things that we're looking for when we assess this pulse. Is it within normal limits as far as the rate goes? Okay, we just want to make sure that it's not too fast or it's not too slow. You know, that Goldilocks zone right in the middle there. So we're just checking to see if things are kind of, you know, quote unquote normal. So we're going to feel that pulse for about 10 seconds. We're going to look for the rate. We're going to make sure it's not too fast or not too slow. We're going to feel how strong it is. Is it strong or is it weak? And then we're going to feel for the regularity, right? Our heartbeats are regular. We can predict when that next heartbeat is coming. It's very regular. So we want to see if it's regular or irregular, right? So again, check the pulse for about 10 seconds. We're looking for rate and the normalcy of it, right? Not too fast, not too slow. We're going to be looking for the strength of it. Is it nice and strong or is it weak or thready, as it's also called? And then we're looking for the regularity of it. Is it regular or irregular? In this case, we'll say that the pulse is strong and regular there and not too fast. Now, we're also, and then we're going to move on to skin condition. Now, we've already kind of looked at this, right? In our general impression. I mean, how can you not look at somebody's skin when you look at them? So we're already going to have observed their skin a little bit. And as we noted in our dispatch notes, that the patient is very sweaty, they're diaphoretic. So we're going to assess their skin color. And really what we're looking for here is signs of shock. Remember, our skin is like a billboard. It's this big giant sign that can tell us, give us clues to what's going on inside of the body. Like, are they perfusing well? Are they getting oxygen down to the cells well? Things like that. So as noted, as we said in the dispatch notes, our patient is diaphoretic. It didn't say anything about them being pale or cold or anything else like that. We just said that they're sweaty, which is a common sign for somebody that's suffering chest pain or heart attack. So in looking at the skin color is good, temperature is good, and the condition, it's diaphoretic. So now we're going to take all this information that we've gathered through our general impression, our figuring out what the mental status is, what the chief complaint is, and any information we've gathered and treatments we've done through the ABCs. We're going to take all that together and figure out what our priority is for this patient. Do we have to get them loaded up into the ambulance and get rolling to the hospital right away? Or do we stay on the scene for a few extra minutes? Do we take the time to take vitals at the scene before we get them into the ambulance? You know, there's lots of things we could do on the scene, including like taking vitals, their history taking, you know, what have your medical problems been? Has this ever happened before, et cetera, et cetera. You know, sometimes we have the time to do that on scene, and sometimes we got to go. We have to load and go and get to the hospital. We can do all of our assessments on the way to the hospital there. So what's the urgency with which we need to move here? So identifying priority patients, making transport decisions, and integrates treatments to preserve life. So basically what we're saying here is that because of a poor impression, because poor general impression, and because of the nature of the chief complaint, having chest pain is pretty serious. So because of that serious nature of the chief complaint, we're going to make this patient a high priority. We're going to transport right away, and we'll take care of our assessments en route to the hospital. Okay, so that's the box there. All right, but what does it sound like when we're doing this? What does it all sound like? So let's put it together real quick, and we'll start from the beginning. Again, we've been dispatched for a 70-year-old male who's experiencing chest pain. When you arrive on scene, you notice that the patient is diaphoretic, he's very sweaty, and they're clutching their chest in obvious pain. All right, so let's start from the beginning. BSI, is my scene safe? Yes. The nature of illness is chest pain. I have one patient. I'm going to go ahead and call for ALS, and there doesn't appear to be any signs of trauma, so I won't take C-spine. My general impression of the patient is poor because of the positioning, doing the Levin sign, and because of their diaphoretic and looking worried. Hello, sir. My name's Joe. I'm with the rescue squad. Can you tell me what's going on today? The patient says, oh, I've been having chest pain for about an hour. I was moving boxes in my attic, and I just started getting this really bad pain. It kind of goes up into my shoulder and my jaw a little bit. It just hasn't gotten any better. I thought it would go away, but it hasn't gotten any better. So the patient tells us that, and so we say, okay, well, I can tell that you're alert and oriented based on how you were talking to me, and that your chief complaint is chest pain. Your airway is patent and self-maintained. Your work of breathing looks good. I don't see you working too hard to breathe, and I can't hear you breathing, so that looks good. I'm going to go ahead and put the pulse oximeter on you to check your oxygen saturation levels. And at 97%, I'm going to say that you don't need oxygen at this point. Looking at your skin here, I don't see any major bleeds that we need to control. I'm going to go ahead and check the pulse for about 10 seconds. You check the pulse. Pulse feels regular, strong, and not too fast or not too slow. And the skin condition looks a little sweaty and diaphoretic, but the temperature and color looks good there. Based on all of this, I'm going to go ahead and make this a high priority patient. We're going to go ahead and start transporting, and we'll take care of the rest of our assessments en route to the hospital. All right, and that takes care of our primary assessment. All right, so again, let me go through that one more time, just a little bit slower there. We'll go through scene size up quickly as we normally do, but then I'll go a little bit slower in primary assessment so you can get a feel of what I'm thinking and what I'm talking about. Okay, so again, same dispatch information, 70-year-old male, chest pain. When you get there, you notice that they're looking worried. He's very sweaty. He's diaphoretic, and he's clutching his chest in clear indication of pain. All right, so BSI, is the scene safe? Yes, the scene is safe. I have the nature of illness is chest pain. I have one patient. I'm going to go ahead and call for ALS, and I'm not going to take C-spine as there's no signs of trauma. A general impression of the patient is poor because of the skin condition and their positioning. Hello, sir. My name is Joe. I'm with the rescue squad. Can you tell me what's going on today? I've got chest pain. My chest has been hurting. I was moving boxes around. It was a little bit tough. I was moving some boxes around. I started to get this chest pain, and so I stopped for a while, but it just hasn't gone away. It actually feels worse than it does. It's kind of going up into my jaw and my shoulder right now. Okay, based on that, I can tell that you're alert and oriented, and that your chief complaint is that you're having chest pain. Your airway appears to be patent and self-maintained, and your work of breathing looks good. I'm going to go ahead and put on the pulse oximeter. It shows you at 97%, so we don't need any oxygen at the moment. I'm going to go ahead and look for any major bleeds. I don't see any major bleeding on the patient. So I'm going to go ahead and check your pulse for no longer than 10 seconds. It feels regular, it feels strong, and it doesn't feel too fast or too slow at the moment. And your skin condition looks mostly good. You're very sweaty, but your skin color looks good, and the temperature looks good. or it feels good. You don't feel cold or anything like that. Because of all of this information, I'm going to go ahead and make you, the patient, a high priority patient. We're going to go ahead and get loaded up into the ambulance and continue our assessments en route to the hospital. All right, there you have it. There's getting through your primary assessment. It doesn't take very long. Now, this box can be tricky because we're learning, it's about what, 1, 2, 3, 4, 5, 6 different things, 7 different things here that we have to do in this box. However, a lot of these things can be, a lot of this information can be gathered just from one place. It's from when the patient talks to us. When the patient talks to us, I can get a lot of information about their mental status, their airway status, their breathing status, right? And I've already looked at the patient during our general impression. So I've already got the status of their skin condition down and major bleeds. When you walk into a room, hopefully you can spot a major bleed happening. So we've already got all of this information. All we really have to do is ask a question. Can you tell me what's going on today? And then when they talk to us, we get their mental status, chief complaint, airway status, breathing status. They're all out of their question. So it's nice and easy. Again, let's go through that real quick. Watch what I mean here. So your patient says, you say, oh, what, you give them your general impression. You're looking at the skin, you're taking clues in from the environment and everything else like that. And you introduce yourself, say, hello, from the rescue squad. Can you tell me what's going on today? So, oh, I've had chest pain and it really hurts and it's been going on for like an hour. It hasn't gotten any better. Okay, so I know his level of consciousness because of that. He answered my questions well. I know his chief complaint because he told me he's having chest pain. I know about his airway because he talked to me, right? They're conscious and they're talking to me. So that means and there wasn't any issues there. There's no signs of an obstruction or anything else like that. So airway is patent and self-maintained. His breathing, full sentences. The work of breathing, if you're working really hard to breathe, you're probably not going to be able to breathe in full or talk in full sentences. They're going to be short, choppy. And then obviously we've already looked at the patient for our general impression. So we get all that information right off the bat. And so we just kind of have to remember the information that we're gathering, kind of file it away, and then flow through all of that information in a nice, organized manner. All right. Now, when we went over chapter 12, we talked about you don't have to do A, B, C's necessarily in that order. However, you should try to stick in whatever area that you're in until it's done. Try not to bounce around too much. Don't do like, okay, I assessed the airway, airway's good. Now let's get to breathing. Work of breathing looks good. And then move on to circulation, and then move back to breathing and put the pulse ox on and figure out oxygen, and then move back to circulation. We don't want to do that. If you do that, it's easy to forget a step. All right. So we want to stay organized and we want to move through this in an orderly fashion. So whatever your order is, whether it's A, B, C or C, A, B, you want to move through the entirety of that section. So move through the airway in its entirety, move through breathing in its entirety, move through circulation in its entirety before you move on to something else. So let's say if this was a trauma patient and they were bleeding profusely when we got to the scene, right? It's exsanguinating bleeding. They're going to bleed out and die. I would start with circulation. So when we assess and control major bleeding, stop the bleeding, and I'm going to take a look at their skin condition and I'm going to check their pulse. Then I'll move back to airway and go all the way through airway and then go all the way through breathing. Okay. It's important to stay organized. So when you start airway, do all of it. When you start breathing, do all of that. And then and circulation, do all of that before you move on to the next one. Keep it organized. You'll be able to get through it much quicker. And if you happen, once we learn this and we get used to it, if you happen to skip something by accident, you'll be able to tell. You'll be able to feel because your rhythm will be a little bit off because something got skipped, and you'll be able to figure that out. All right, so let's keep it nice and tidy. All right, one last time, and then you can practice. All right. So dispatch information is a 70-year-old male experiencing chest pain. When you arrive on scene, you notice that the patient is sitting upright in a lazy boy chair in his home, clutching his chest, looking very worried, and his skin is very diaphoretic. Okay. BSI, is my scene safe? Scene is safe. Nature of illness is chest pain. I have one patient. I'm going to go ahead and call ALS, and I'm not going to take C-spine as there's no signs of trauma. The general impression of the patient is poor because of his skin condition, the diaphoresis, and that he's clutching his chest and obviously appears to be in some amount of pain. Hello, sir. My name is Joe. I'm with the rescue squad. Can you tell me what's going on today? Feel chest pain. I was out raking leaves in the yard, and I was out there for a while, and I just got all this chest pain. It hasn't gone away. It's just, it feels terrible right here in my chest. It's kind of gone up into my neck, my jaw, and down into my left hand, down my arm there. It's just not feeling good. Like, okay, well, I can tell that you're alert and oriented, and that your chief complaint is that you're having chest pain. Your airway appears to be patent and self-maintained because you're talking to me. Your work of breathing looks good. I'm going to go ahead and put the pulse ox on. It shows 97%. So at 97%, I don't have to give you any oxygen at the moment. And looking at your skin condition, you look diaphoretic. However, I don't see any bleeds that I need to control or anything else like that. I'm going to go ahead and check your pulse. And feeling your pulse, that feels regular. Feels not too fast, not too slow there, and it's strong. So based on these things, I'm going to go ahead and make you a high priority patient. We're going to go ahead and load up into the ambulance and get rolling to the hospital, and we'll get our secondary assessments done en route. And there you have it. All right. So in practicing this, just go ahead and give yourself some dispatch information. All right. Let's make it easy at first. Right. Let's have somebody that is experiencing chest pain after they've exerted themselves. Maybe they were raking leaves in the yard. Maybe they were at work pushing heavy boxes around or something like that. Okay. So have them experiencing chest pain after exertion, and maybe they've been feeling it for an hour or two. It hasn't gotten better, or it's gotten worse, and maybe the pain goes places, something like that. So just have a little thing for your patient to tell you how they're feeling. And then just work through slowly your primary assessment. All right, let's pretend that you're talking to this patient. Now, remember, we've said this before, but it's always important to remember when we're doing these assessment sheets. If it's happening in your head and it's not coming out of your mouth, you're doing it wrong. We have to remember that, our evaluators are going to be taking their eyes off of you at some point to mark these sheets. And so if you say key words while they're looking at the sheet, if you say these key vocabulary words like, assessing skin condition or patent and self-maintained, if I'm looking at the sheet to mark you down for something that you've done and I hear you say patent and self-maintained, without seeing you like do stuff, anything, or looking at the airway, then I know that you did it. So we have to make sure we say some of these things, right? So go through this slowly, be clear about what you're saying there, and just practice. I'll be sending out the basics for dispatch information for medical patients here shortly. You should receive those in your emails. And so you can just, you can take that information and just apply it to here. So at the moment, let's just go through and give ourselves a pretend patient. Let's make it easy. Let's make it like trouble breathing from asthma or chest pain, something like that, something where the patient was conscious and will be able to talk to you. We'll move into different things like patients being unconscious or unable to communicate with you, and how we tackle those things in the primary assessment. We'll get into that after we establish this as kind of a baseline there as a foundation. All right, there you have it for doing your primary assessment through your medical sheet. Go ahead and practice, get in the mirror, do it while you're brushing your teeth, while you're at a stop sign, right? Start with your scene size up and then go into your primary assessment. All right, again, we should be off the sheet for scene size up. You should be using your sheet now for primary assessment until we get good with it. Start at the beginning. Doesn't take long, 5 seconds, right? For your scene size up in doing this sheet. So it doesn't take long. So start there, work through your primary assessment and just practice, practice, practice. Again, this is a model for how we do things in the real world. So it is essential that you understand not only how to do this, but the flow of it, the flow of a call, the flow of assessing things, recognizing things on a patient, and taking that information, cataloging it, and then applying it to decisions that we need to make. All right, that critical thinking aspect there. All right, if you have any questions, go ahead and shoot me an email, and we'll see you guys. We'll see you guys very soon. Thanks.